So I want to thank you for joining us for this instructional webinar regarding phase 2 of the 24/7 RN reporting trial that's being expanded to all MPS sites in 2025. My name is Tanya Clancy, Assistant Director in the MPS section and lead for the 24/7 RN reform trial. I will be hosting today's webinar alongside my colleague Shirley Shaw. Today will include a formal presentation and then a walkthrough of completing the 24/7 RN reporting template. We will be holding a question and answer session at the end. This webinar will be recorded and will be made available on our MPS Reforms webpage. So read questions as well as any comments or concerns can be submitted using the Q&A functions in Teams throughout the presentation, and you don't need to wait until the end. And I would encourage you to do so to make sure this session is as interactive and as useful as possible. So if you do have any questions, please ask them. We will try to get to as many questions as we can, and if we can't answer them today or we run out of time, we will make sure we publish written answers on our MPS Reforms webpage along with today's presentation. So that's it for housekeeping, but before we begin, I would like to acknowledge the traditional owners of the lands on which we meet today all across Australia, where we live, learn and work. I would like to pay my respects to elders past and present and to any Aboriginal and Torres Strait Islanders people here with us today. So what do we intend to cover today? So the first slide outlines what we intend to cover today. And so we will be providing you with background to the 24/7 RN responsibility and speak to exemptions, regulation, how the trial came about, and what happened during phase 1 of the trial. We will then talk to the findings of the phase 1 trial, talk about phase 2, and then a demonstration on how to complete the manual Excel 24/7 RN template. And considering we will be managing reports for all 183 MPS sites, we want to ensure everyone is familiar and comfortable with this process. Lastly, we'll do a quick summary and highlight key points, and then hold a Q&A session to provide an opportunity for you to ask any questions you may still have at the conclusion of the presentation of the webinar. So first of all, we wanted to give you a little bit of background. So the 24/7 RN has been in mainstream residential aged care since 1 July 2023. And as you may know, the aim of it is to improve the quality of care that residents receive by ensuring that they have access to the highest level of clinical nursing care to meet their needs at all times. It is the government's policy intent that 24/7 RN coverage becomes the standard across the sector, including MPS. Implementing 24/7 in MPS also aligns with the recommendation 86 of the Royal Commission into Aged Care Quality and Safety. All mainstream providers must meet the 24/7 RN responsibility by having at least one RN on site and on duty at all times at the residential facility or facilities they operate, unless they have an exemption in place. So, exemptions and regulation. Mainstream residential providers operating small residential facilities in rural and remote areas can currently apply for an exemption from 24/7. These facilities must be located in MM 5, 6 or 7 and with 30 or less operational places. And the site must have taken reasonable steps to ensure the care needs of residents will be met during the exemption period and will still need to submit the 24/7 RN report each month during their exemption period. And the Aged Care Quality and Safety Commission is responsible for regulation of the 24/7 RN responsibility. So what's the current obligation? So whilst MPS are not obliged to report under 24/7 under the current Act, it will apply to all residential care homes under the new Aged Care Act. So under the new Aged Care Act, for the purposes of 24/7 responsibility, a residential care home includes a place within or co-located with a hospital or other health service that is covered by an agreement with the Commonwealth to deliver aged care services alongside health services as part of an integrated service agreement. So implementing the MPS, so what happened? So in March 2024, the MPS working group agreed to trial 24/7 RN in MPS with a phased approach. The MPS working group established a reform subgroup to develop and lead an agreed approach to the trial and implementation of aged care reforms in MPS, which included 24/7 RN. In July 2024, Phase 1 commenced in participating MPS trial sites submitting 24/7 RN data for the months of August and October 2024. So this is just a slide that shows you the trial implementation timeline, and I don't expect you to be able to see it. It is hard to read. There's a lot on this slide. You will see that the planning phase and Phase 1 trial has been completed, and we're now in Phase 2 of the trial. So what happened in Phase 1? So 60 sites were nominated by MPS working group members from most states and territories, and a range of policy guidelines and reporting guides were developed and provided to trial sites for use and guidance during Phase 1. A manual Excel reporting template was provided to sites to complete data for the months of August and October 2024. Sites were also asked to complete an online survey of their experience of reporting 24/7, and the majority of MPS sites found the reporting for 24/7 RN was relatively easy and not too time-consuming. So what were the outcomes of that trial in Phase 1? So we had 57 trial sites submit data for August and 59 submitting data for October. The MPS team travelled to 22 sites to support trial participants and were warmly welcomed by management and staff, and insights gained by the team during these visits was invaluable. And initial findings confirmed the initial assumption that the integrated care model of MPS meant most sites already met the 24/7 RN responsibility, as the majority of MPS have a health service, which means an RN is on site and on duty 24 hours a day, 7 days a week. Phase 1, though, did identify some nuances with a small number of MPS, namely those with a lower acuity lodge or hostel located separately from the main MPS site. And during this phase, we are keen to identify exactly how many of these sites there are across all 183 MPS sites, and to help determine whether current mainstream exemptions are fit for purpose for MPS. So this is just a pie chart that shows you that the level of RN coverage is reported. So during Phase 1, there was a high level of compliance, with 86% of sites indicating they met the 24/7 RN requirement, and only 8 sites reporting that they did not meet or only partly met the requirement. So with the sites not meeting the 24/7 RN requirement as they reported, there were essentially two reasons. One was that the sites reported an RN absence due to the RN they have being occupied with acute and/or emergency patients. The second one was the sites that have a low acuity lodge or hostel not co-located on the main MPS site that isn't staffed by RNs 24/7, noting their main MPS site also has aged care beds where they do have an RN 24/7. So sites not meeting the 24/7 RN. So what we did after the August data was submitted is we provided clarification to the MPS sites regarding the definition of on-site and on-duty, being that if you have staff employed to work across both the aged care beds and the acute health ED beds, and they are unable to attend immediately to the aged care beds, i.e. the RNs may be dealing with an emergency in ED, they are still considered to be on-site and on duty, as normal triage processes would apply. So even though they can't go straight away, they are actually still on-site and on duty. An MPS with a main hospital and a separately located lower acuity facility were asked to report on both facilities separately. So we actually got them to copy the report, put it on a new tab in the worksheet. So that way we could identify that the main MPS site met the 24/7 responsibility, and the site that was located away from the main site, but which usually had lower acuity residents, did not meet the 24/7 requirement. So what happened after we concluded Phase 1? So the MPS reforms implementation subgroup and subsequently the MPS working group were presented with findings from Phase 1 of the trial. An agreement was made to move to Phase 2 with all MPS sites to submit data for the months of March and May 2025. It was also agreed that formal implementation of 24/7 RN would be extended to occur no earlier than 1 October 2025. We just wanted to acknowledge that providers who participated in phase 1 completed the required report and survey, and in some cases, as I mentioned before, hosted our team for site visits to discuss experience. Your collaboration was greatly appreciated and has allowed collaboration and progression of the 24/7 trial. So thank you for that. So phase 2 of the trial. So as outlined earlier, all MPS are required to participate in phase 2, including sites who participated in phase 1. Reporting is to be completed and submitted for the months of March and May, and then we will ask you to complete an online survey at the end of May, early June to gather feedback on your overall experience of reporting 24/7 responsibility. We will be providing you with a range of guidance materials to assist you in participating in phase 2, and these will be distributed following the webinar to the email address used to register for today, and will also be made available on our MPS Reforms webpage. Findings from phase 2 will then be discussed with the MPS Reforms Implementation Subgroup, and a summary of outcomes and recommendations submitted to the MPS Working Group prior to full implementation under legislation, which, as I said, is expected 1 October 2025. Now, the reporting template you'll be using for March and May is the same reporting template that's used by a small number of mainstream residential aged care providers who are unable to report through GPMS. And it's noted that the majority of mainstream residential aged care providers report 24/7 RN directly into GPMS. We are working with our IT colleagues presently to have the 24/7 RN reporting functionality turned on for MPS sites, so you can use GPMS to report. Noting MPS currently use GPMS to report on food and nutrition. We are hoping that GPMS functionality will be available from 1 October 2025, and we will keep you updated as to progress on this, noting, as I'm sure you're all aware, IT changes can sometimes take quite a while. So again, we want to work with you to ensure that we provide you with the necessary support and guides during the trial. As outlined earlier, all sites will receive a trial guidance pack shortly. These will also be available on our MPS Reforms website and will include an FAQ, a detailed reporting guide, and policy guidelines. The specific policy guidelines include the definition of on-site and on-duty and include a number of scenario examples for you to look at. Our team will happily respond to any questions via our Reforms email address, and during the reporting months of March and May in particular, if you need us to call you and take you through anything, please just shoot us an email and we'll respond very quickly. The MPS webpage is also another very useful resource and a one-stop shop for all things MPS reforms related. We're also happy to set up one-on-one Teams meetings for any sites that feel like they would require further assistance or information. So a couple of key points before we go to the demonstration. There is no 24/7 RN subsidy available for MPS, unlike mainstream. And this is because the majority of MPS already most likely meet the requirement due to their co-located health service. Remember, we will be sending an online survey to complete after May's reporting period, and that guidance materials will be distributed to you after this webinar. Again, the outcomes of phase 2 will be presented to the implementation subgroup and the working group before finalising any changes to exemption requirements and formal implementation on 1 October. I should mention that the survey actually asks some questions about the exemption requirements, so you will have an opportunity to provide feedback there. And as mentioned, we will provide you with updates regarding automating the reporting of this requirement through GPMS from 1 October 2025. And lastly, before we go to a demonstration, just a reminder that on-site means the RN must be within the confines of the MPS or the immediate surrounds. And on-duty means an RN must be available to provide care to residents or oversee care provided by other staff, but your usual triaging principles apply. So if your RN is called up in acute or emergency, they are still considered to be on site and on duty for the purpose of this requirement. So now we get to completing the report. So I'd now like to hand over to Shirley Shaw, who will run you through a small demo on using the 24/7 RN report. Thank you, Shirley.
Thanks, Tanya. I'm just going to bring up the report so I can share that with you and give you just some high-level tips about using the Excel template. So as you can see on your screen, this is the template that we'll be using. Now, you will notice that there are two tabs within the report, with the first tab being the instructions, which will give you a step-by-step process of how to complete the form. This can be used in conjunction with the reporting guide that we will give to you, but if this is all you got, we'll definitely give you a step-by-step through doing that report. The second tab is where you will actually enter the data for the report. This tab can actually be duplicated for those sites who will be required to report for a second site, i.e. those ones that Tanya mentioned about the lower acuity sites that were nearby to a main MPS. In order to do this, it's as simple as right-clicking. You can move or copy, and I strongly suggest that you make a copy to the end, and you'll see once I do that you will end up with two tabs at the bottom. And now it hasn't done it, so that's really annoying. But I promise you it does work. Sorry, a few IT things going on here. So the first section here is to be completed and involves your site details. So there's 5 fields to complete, and all are pretty much self-explanatory. I just wanted to highlight the last field is important to the MPS team, as this will highlight to us any of those sites that will require 2 addresses. So i.e. the main MPS and the off-site lower acuity. This especially is going to come in handy with the transition and deeming process, where we need to get a clear understanding of exactly the exact location of all our MPS sites. So whilst it won't be used specifically for that, it's definitely going to feed into that information. So if I'm coming down, this is where you will come into the recording sections, and the days of the month will already be populated for the exact number of days for the ensuing reporting month, so i.e. March and May. We've highlighted the weekends just to try and make this a bit easier for those who have different staffing structures over the weekend. One thing that did come out of our visits was that we have, especially in the lower acuity lodges, they might have an RN for part of the day or all of the day, or particularly for, but not necessarily staffed over the weekend. Column B is purely a yes or no answer. In the majority of cases, most of our MPS will be a yes, and that is easily entered. It's a free text, so you will enter yes. And as with any Excel spreadsheet, you can drag and copy that down the column. For the MPS who meet the requirement, filling in this column by doing that, by typing yes in the first one and dragging all the way down to the bottom, is as much as you need to do for the overall report. Once you're doing that, it will show up that the RN percentage of coverage is 100%, and there's no hours listed that an RN was not on duty or on site. So that is for those who meet the requirement. For anyone who answers a no in column B, you must then complete column C's and D, where you will record the start and end time that you did not have RN coverage for 30 minutes or more. So for argument's sake, on the 1st of March, there was an incident where the RN went home unwell or whatever, and it's in some of the MPS who have a sole RN working across the MPS, and it took time to get somebody to come in. So what you would do, the start time was, for argument's sake, it was 2 o'clock in the afternoon. Hours always have to be entered in 24-hour time format, and it took an hour for the nurse to come and cover and the new nurse to come on cover. So you'll see automatically the column E will outline that for an hour on that day, there was no RN. When you move across, you do need to then fill in for any no entry and any time data entry entered. You do need to complete columns F to I. All these cells have a drop-down function to give you options that can be chosen. So whether it was planned, not planned, the reasons why, who had responsibility, and the person's providing care, and if they had access to support, so i.e. the EN was there and there was an RN or a nurse unit manager on the main site or off site who was on call, who could answer any critical questions, and whether they had access to clinical records. You will see also that because data has been entered in there, that down below, that now shows that through that period, the percentage of RN has changed, and the hours the RN was not on site is registered as 1 hour. And I'm just doing one line at a time. I won't do the whole spreadsheet because that will be time consuming. So once all those columns are filled in, there is also a separate section. Again, this only needs to be filled in if you are recording a time when an RN was not on duty and on site for more than 30 minutes. This is a combination of drop down and free text. So you can enter information in there. So in a nutshell, I know it's a very quick overview of how to use, but that is the key information of how to complete the time. If we've got now, I think we'll have a look at any questions, because I do know it was quite quick, but I didn't want to go into too much detail. But definitely the reporting guide and all the instructions on the first tab will definitely help with any questions or answer any scenarios that you might have. I'll hand back to Tanya.
Thanks. Thank you, Shirley. Yeah, and just on that reporting template, Shirley gave you an example of when an RM was away for, say, an hour. If you've got an environment where you have an RN on, say, in a lower acuity lodge 5 days a week during the day shift, you will actually need to identify the exact times you didn't have. So for, say, on the 1st of March, you wouldn't have an RN between 00:00 hours, so 12 midnight, until, say, 7:30 in the morning when the RN comes on. And then again, when the RN leaves at 4 o'clock, you would then need to put another absence for that same day from 4 o'clock to 11:59 p.m. So you may find that on some of those days, you will need to insert another row, and there are instructions in the reporting guide on how to do that. So can now open it up for any questions that people might have.
I can see we've got one from Andy Wu from WA. Thanks, yep. Andy. The time to column D, does not allow us to enter 24.00, e.g. if we didn't have an RN on site from 8 p.m. till 12 p.m. Do we need to enter 20 and
23:59?
Yeah. So what you need to do, Andy, is the end day time will always end. The day always ends at 11:59 p.m. So it will be 23:59, and then it will kick back in from midnight onwards that you have cover. So I hope that answers your question.
We got another one from Barney. Apologies for my pronunciation. Advaru, do rows 51 and 52 capture the same data? we're just going to have a look back at that report. So whilst Shirley's having a look for that, we'll come back to you. Catherine Hiller's asked a question, when does the reporting period start? So it starts on the 1st of March. So you'll be reporting for 1st of March to the 31st of March. And then again, you'll be reporting from the 1st of May to the 31st of May. So we're just covering a whole calendar month for those 2 months.
The question from, sorry, I forgot who it was, but as far as 51 and 52, that will automatically calculate. The worksheet actually has a hidden protected formula with the time entry data being put in. So the percentage of RN will automatically calculate. It's set at 100% that if everyone meets the requirement, but as soon as you start entering a time period where an RN was not on site, columns 51, 52 will automatically update under the summary, and the hours an RM was not on site and on duty. That will automatically calculate those tallies. You don't need to do any additional calculation yourself, except for entering the time data.
Thanks, Shirley. So we have another question, which is why we're not reporting for April. And we're not reporting for April because we wanted to give MPS an opportunity to submit data for March. And then if there are any queries or questions or feedback and there's anything we might need to change, we don't expect to, but we wanted to provide that space in between to be able to review the process with our MPS phase 2 sites.
Jan Falconbridge has asked, where do we get our service ID? Service ID, your service ID matches your GPMS ID. Now, that will be, even if there are multiple sites, you'll probably find that GPMS ID is the same across, but that is where you will find that. So it's the GPMS ID that you use to report your food and nutrition reporting in GPMS.
Okay. Wynne has asked a question, can you elaborate on immediate surrounds? Yeah, so if an RN is outside of the building but still on the grounds of the MPS, they're considered to be on the immediate surrounds. If they're actually outside and down the road at the coffee shop buying something, they're not considered to be on the immediate surrounds. We did visit a couple of MPS that had the aged care, they were located on site, but the aged care beds or area was across a walkway. So that's considered to be on immediate surrounds anywhere within that vicinity. So I hope that answers your question, but let me know if it doesn't.
We've got a question from Liz Uncles. Thanks, Liz. Wondering if the RN care ratios will apply to MPS and if the definitions of on-site, on-duty as applied to the 24 care minutes will apply. So I think the question's more regarding the direct care, I imagine.
Yeah, I think that, yeah, Liz, is it? Yeah, you're asking about direct care. So the direct care minutes are calculated through, in mainstream residential aged care, are calculated via the ANAC classifications assigned to each resident. So the care ratios aren't applicable within 24/7. The 24/7 RN requirement is whether you have an RN on site and on duty for 24 hours a day, 7 days a week.
And Liz, we'll go a little bit more into what's happening in the phase 2 of direct care targets in our webinar which has been delayed till Friday, the 28th of February. So definitely we can cover that a little bit more and a little bit more understanding of where we're going with that. Got a question from Karina. Is there any way the form can be more automated? Seems very basic at the moment, requiring a lot of data entry, drop-down boxes, etc. Look, unfortunately, because of the constraints, and this is a reporting template currently used for mainstream, we are restricted with using that. We have tried to duplicate what's being used in mainstream as much as possible to reduce timeframes of getting MPS into GPMS and the massive costs that have been quoted to us for making any supposed simple changes to an Excel spreadsheet, which seems absolutely incredible. So we have, whilst it does seem a bit clunky, I think it's kept basic for a reason and made to keep as simple as possible. But that is definitely the reasons why we are trying to stick with what is currently there and being used.
Yeah, and certainly if you have a fixed roster where you don't have RNs, you only have RNs on duty, say, during the week in a lower acuity lodge or hostel, you can copy and paste, the option that you pick in the drop-down box. But yeah, we do need each site to identify by clicking on those drop-down boxes the reason why and what care was in place during that absence.
One thing I might actually just add is with the reporting for each month, we are aligning the due date with what is currently applicable to mainstream and what will be in the norm once it's fully implemented, and that is that you have 7 days after the end of that month to submit the report. We have been in touch with the MPS working group members, and we are streamlining getting the reports out. As you can understand, we've got 183 MPS and 2 main leads in the trial team who's managing all these. So we're trying to consolidate it as much as possible. So we are definitely working on getting them out at a regional level that will then be submitted to sites individually through your internal communication channels. And then sent back to us either by the same way or directly, and that will be articulated when they are distributed by your necessary local regions.
Yeah, so following on from what Shirley said, so you should receive the report. We're hoping about a week before you need to start to complete it. So these will be going out to our MPS working group members shortly, as Shirley said, and distributed through networks. So in some cases, some jurisdictions will be asking that all of their 24/7 reports go back through them to come to us. And there may be another jurisdiction or two where there's only a small number of sites and those reports can be sent directly to us from the sites. So we'll let you know exactly what the process is for your jurisdiction.
I've got a question from Kylie. If there are only 2 staff on shift in an MPS and the RN is busy in ED for hours, e.g. 5 hours, does this need to be flagged as although the RN is on site, they are unable to leave the ED to attend to a resident or to give scheduled medications?
Yeah, look, that's the sort of question that we received last time, and no, they're still considered to be on site and on duty. I suppose it would be if you had an RN in the aged care area and someone suddenly became very unwell, that RN would be attending to an aged care resident and potentially unable to attend to the needs of another aged care resident within a certain period of time. But for this purpose, if they are employed to work across both aged care and the acute emergency side of the health service, and they're there, then they're 24/7. Yeah, you don't have to report names. For the requirement. Yeah, for this requirement, they meet that requirement.
Yeah. Yep. Jossie has put in, is after hours nurse manager considered to be an RN on site if there is an EN on duty at the residential aged care attached to the MPS?
So where's that one again?
So this is at the top.
I haven't got it. Oh, okay. Okay, I think it depends. We might have to get back to you on that one, Jossie, but I think it would depend on what the after hours nurse manager is actually doing. So I think if they're employed and they can actually be undertaking clinical duties, then they would be considered. If they're there and they're doing, I suppose, a lot of admin, then would need to check on that. But if they're on site, I'm thinking that if they're on site and on duty, then they would be considered. And the rack attached to the MPS would need to be co-located. So it couldn't be one of those low acuity sites located down the road. That would be a no. But if the aged care beds that you're thinking of are actually located on the same site as the MPS, then yes. Yep.
We actually saw this with some of our very small and more remote MPS, where there was a sole RN that was staffed across the whole thing, and that is the acute and the aged care, and that same thing. They were there, they're on site, and they're available, and as I said, for this requirement,
Yep.
that is being met. We've just got a new one come through from Jennifer. Does this also apply to a nurse unit manager on site and on duty?
Yes.
If they are a registered nurse, yes, and they've got clinical skills and on site and on duty, yes.
Yep.
Just have a look. I think no, they're still coming. I've got another one.
So this is from
Murray.
So referring to the South Australia Health EBA, we must have the RN in acute and minimum staffed 1 RN and 1 EN if they leave to go. This leaves the acute hospital without an RN in separate building in breach of the enterprise agreement. Yeah, I think that's a unique situation, Murray. So if there is a legal requirement for your facility that the RN does not leave the acute hospital and walk across to see to residents in the aged care facility, then you would have to report that you did not meet the requirement.
Especially if it is in their contract that they are not allowed to physically leave the hospital, then yes, I agree.
Yeah.
But I would wonder that if there was an acute emergency in your aged care, i.e. a resident went into cardiac arrest or something, whether the RN would leave to do that. But I'm not sure. We might. I know we've had this discussion, but we
might need to talk
a bit more about it, because it seems to be a bit out of an individual thing.
Yeah, we might probably just need to understand it a little bit better, those particular circumstances. But definitely, if they're restricted, in their EBA to leave and go into the aged care, then at this stage we'd be saying it's a no, you don't meet the requirement. But we'll talk to you offline.
And it'd also be good to understand that if the RN is in the hospital, whether the aged care staff, i.e. the EN, has access to the RN to discuss any concerns and escalate as necessary, and whether they are then transferred off-site or that. So it's all those nuances that you need to unpick a little bit more to determine whether there are adequate coverage or adequate support to ensure that aged care residents, if they require, that higher clinical level of care or oversight, that it is available to them. And that's what this initiative is all about, is ensuring that aged care residents have the availability of that clinical experience of an RN.
Yeah.
Which may not necessarily be in person.
Yes.
I think we might have come to the end of our questions. I hope we haven't missed anybody. We've got the lovely Karina in the background. There's some in the chat. Sorry, I've just found some in the chat. You have a look. So when does the reporting period? We've done that. Why we skipped April?
Yep.
Oh, has the link for the 28th been sent out as yet? Yes, Catherine. So if you want to flick me your email address, I can absolutely forward that. As you can imagine, with these webinars, we have a huge distribution list. We try to capture as many people as possible. So we do have a simple Excel spreadsheet that we just plonk everybody's email address in. So feel free to send that to me via the MPS Reforms email, and I will get that link to you today. I think that was all in the chat. I'll just go back to the Q&A. I think we have come to the end of questions. So we have managed to get that done under an hour. So either we're very good or you're very, very clever people. So
yeah, look, we want to thank you all for dialing in today. It's an exciting time. We'll be very busy for MPS with the implementation of all of these reforms, and we want it to obviously go as smoothly as possible for our MPS sites. And we really appreciate you participating in phase 2 of this trial, because what we want to do when we do implement it, we want it to be something that's fit for purpose and works for MPS and caters to the particular nuances of MPS, particularly in respect to any exemptions that we might need to look at. Noting in mainstream, exemptions, as I mentioned before, for MM5 to 7 and 30 or less beds in rural, regional, remote, has been extended to 1 July 2026. So at this stage, we're not sure what's going to happen post that period, but obviously we'll keep you informed of that as we go along as well. So just one last call out for any questions that anybody might have. As I said, Q&A will be put up on our website, and we're happy to, if you'd like a chat with us further, please send us an email and we're happy to arrange a time. Okay, so if there are no more questions, we can finish a little bit early. So again, thank you all very much for participating today.